All right. Hi, everyone. Thanks for joining us tonight. We're going to give everyone just a few minutes to get logged in. Let me change my name. There we go. All right. And tonight we'll have some parts that are interactive. And by that, I mean, we're going to ask for you to answer some polls, but also we would love for you to be interacting in the chat. We'll have some questions that we're going to ask for you to answer. So you can keep cameras off, keep microphones off, but even if you walk around or doing something else while this presentation is going on, just try and stay a little bit close because we'll have some questions, but love some participation, okay? I'm going to give everyone probably just about 2 or 3 more minutes before we start with some introductions, and then we'll get started. And I'm going to pull up our slides. All right. Kayla, can you see that okay?
Yes, it looks great.
Okay. We have chat here. All right. All right. We'll give everyone about 1 more minute or two, and then we'll dive right on in. Okay, everyone? All right. Well, why don't we dive in and get started? Good evening, everyone. My name is Dylan Eiger. I'm one of the tutors here at Elite Medical Prep. I really appreciate you all joining us tonight for our USMLE Step 2 Bootcamp. We're really going to take this time as an opportunity to tell you our thoughts about kind of the most high yield things that we want you to know in terms of how to be best prepared to not only take step 2, but then really study for it along the way. So it'll feel like a pretty broad overview of what we think are the most high yield tips and tricks in terms of preparation and studying. But know that there's a lot more information that we have to offer, and we want you to ask for that. So throughout the night, we're going to have some polls, just a few, some questions, and we really want this to be interactive. So when I'm speaking, Kayla's going to be monitoring the chat and vice versa. So ask away, add comments, thoughts. This is a judgment-free zone. So if we go through questions and people want to just throw out answers, even if they're right or wrong, we don't care. We just want to hear what you're thinking. And importantly, if you have questions, please ask them as the night goes on. We will have a dedicated time for Q&A at the end. So if we think the question is better addressed then, we'll kind of table it for now and then answer it then. But we would rather you ask questions as we roll through. Okay? So let's get started. Do you want to go ahead and introduce yourself and I can follow?
Absolutely. So I'm Kayla Frye Bourque. Just call me Kayla. I'm one of the EMP tutors, but I am a practicing pediatric emergency medicine physician in Massachusetts.
Awesome. And I'm Dylan. I'm currently a cardiology fellow in Philadelphia. Um, I've been with Elite Medical Prep now. I think this is my 7th or 8th year. So I've been tutoring for quite some time, but it's been fun to put on webinars like this where Kayla and I have kind of been through the entire USMLE process. And now we have time to not only reflect back on it, but see how things have changed over time. So we hope tonight you'll get some insight in terms of what our thoughts are on the current state of step 2. So before we dive into that, just a little bit of background about who we are. So we're really kind of a multimodal medical prep company. So while the majority of what elite medical prep is in terms of tutoring and helping students prepare for different aspects of medical school, starting with the MCAT all the way up to board exams and licensing exams, we offer a lot more than that. We work with a lot of different medical schools around the country and around the world. But like I said, most of what we provide is one-on-one tutoring for really anything. So I'm sure Kayla has similarly tutored students for step one, step two, step three, and then shelf exams. I'd say those are probably the most common things that we spend time with students focusing on. But I've also done MCAT, residency advising, I've done licensing exams. So we really cover anything across the spectrum. And it's, the thing that I like that we provide is it's really meant to be personalized and specialized. So that's what we want to offer you tonight is yes, we have a presentation that's meant for the general audience, but we want this to be also highly customizable to what you are all experiencing and thinking about. So um, when we think about achieving success on step two, I think there's a really simple formula. And I was actually part of a boot camp presentation on step one. I'm not if any of you were there, but I'm going to make a lot of relation or references to step one, just because I think many of you will be familiar with what that test was and the preparation that went into it. But we're really going to focus on the differences. Obviously, step one now being a true pass-fail exam, and step two being technically pass-fail, but it's obviously heavily used in the residency selection process. So the score is really important here, and step two has become now that test that everyone focuses on. When I was a medical student, step one was that test, but times have changed. So the three things that I think are the most important: early preparation, much, much earlier than step one, which we'll talk about why. High yield resources, which is the same as step one, but I think most importantly, your scope of focus is much more limited, which we'll get into. And then similarly to step one, I practice test. Now, obviously, the way we use practice tests will be different because you're not only assessing readiness for the examination, but you're also assessing your success and that level of success. So we'll kind of dive into a few of these things. And um, starting early is probably the most important recommendation that I make to students. I'll often get students coming to me when they're just entering their step two dedicated period. And the first thing I ask them is, okay, how much of the question bank or of UWorld or Amboss have you done? For me, it's kind of the most important prognostic factor in terms of how much effort are you going to need to put in to get to your target goal. So with step one, starting de novo at the beginning of your dedicated period is not awful. That's actually pretty common. But for step two, we highly recommend against that. And your preparation for step two should be very slow and steady. And I tell all of my students, start working through your questions during your clinical year, your that MS3 year at most schools. As you're going through the different core clerkships, medicine, surgery, psychiatry, etc., you're going through the questions in preparation, not only for your shelf exam, but that's laying the foundation for your dedicated period for step two. In an ideal world, what I advise to people is by the end of your MS3 year or your core clerkship year, ideally you would have all of your question bank done. So when you hit that dedicated period, it's simply review. You're now able to focus on practice tests, which we're going to talk about in a second. But you then you kind of know what your weaknesses are heading into dedicated. So you'll be able to not only focus in a high volume, high repetition environment where you're doing lots of questions, but you'll be a little bit more informed with how you spend your time. So the number one recommendation I think I can make is start early, slow and steady, go through questions throughout the clinical year, take practice tests for the shelf exams, and really use this as the foundation for your dedicated period. Kayla, what are your thoughts on this approach? Do you recommend the same thing? How would you go about this?
Absolutely. I completely recommend the same thing. My students will often be like, should I start studying for step two? When do I need to start studying for step two? And I remind them, your clerkships truly are your studying period. That is when you are working through and learning the material so that way during your dedicated time, you don't have to relearn things.
Yeah, spot on. So I think, we're in agreement. Start early, slow and steady, and this is the best way to prepare yourself. Now, for anyone who's on tonight, if you haven't done that, I don't want you to think all hope is lost. I've had many students who only get through 30%, 20% of the question bank during their clinical year. And then they enter their dedicated period, say, hey, I have 3,000 questions I need to do. It's not impossible to get the score you want if you just start effectively from the beginning of your dedicated period. Just know it's going to require a lot more effort. It'll be much more challenging, but it's still possible. But across the board, this is the recommendation we're going to make because not only will it prepare you for your shelf exams, it'll make you a better medical student when you're on the wards, rounding, presenting to your attendings, and it's obviously going to help you with your step two score. So moving on to the next part of this is how do you study? What are you actually going to be doing during your clerkship times and then also during your dedicated period? So unlike step one, step two, you should have blinders on and there's like very few resources. Step one, there's a million resources. There's a million ways to skin a cat for step one. For step two, there's less ways to skin the cat. Um, and we're going to hear Kayla's perspective, but what I recommend is, as we've already said, a question bank. When I was in medical school, everyone used UWorld because that's what was available. Amboss is a great option, as there are many other question banks out there too. We have no stake or preference for one. We probably have a personal preference, but as a company, we don't have one. But UWorld and Amboss are definitely the ones that we recommend just because they're so commonly used and they're well tested. So that is effectively a non-negotiable. You should all be using a question bank. And then after that, the only other thing that I always have to recommend is practice tests. Like that's also a non-negotiable. Whether it's from the test bank manufacturers, UWorld and Amboss, but ideally from the actual NBME. All right. So those are the two things that you need to have. Now, in my experience personally, and then through tutoring, I found that it's not possible for most humans to just do questions all day without getting bored. So because I recognize that, I will often recommend you get one or maybe two other resources, not only to supplement the learning, but really to give you some variety throughout the day. And I personally am someone who likes to read, so I recommend textbooks. First Aid has a textbook. Step Up is another company that has a textbook. But then there are many other things out there. There's lots of videos online. People use flashcards. Um, I just recommend picking one other simply to break up the day, make it less monotonous, and give you a place to reach when you are struggling with a specific topic. Um, the key thing I want you all to know is a big difference between step two and step one is that there's no comprehensive resource for step two, in my opinion. So what I mean for that is if you actually read first aid for step one, that has almost all of the material, like all the high yield material you need. It's not the case for step two. There's so many permutations and possibilities of questions that they could ask you that it's not possible to fit that in one book or one video series. Even if you do all the questions in UWorld or Amboss, you still will see things on test day that are new, just because of the breadth and the wide scope of what's tested on step two. So I tell my students, don't feel like you need to do 16 resources, do them all to learn everything. The truth of the matter is you never will. And that's medicine in a nutshell. So question bank, practice tests, and one other thing to break up the day and help you focus in on those areas you're weaker in. Kayla, what are your thoughts? What's your approach and what do you recommend?
I could not agree more. I personally love UWorld. I think it's because it's what most people are familiar with. But I actually do have my students use specified questions in Amboss because of the new types of questions that we're seeing on USMLE Step 2. Amboss has been able to update and has patient chart type questions, which UWorld does not have yet. And so I do actually recommend students using Amboss for those types of questions so they get used to that format since we're not seeing it on UWorld yet. hopefully coming soon, because we all know that we all love UWorld. But Amboss does offer those different format type questions, which are new in the past couple of years to step two. As far as textbooks, I agree. I think these are some of the most popular. I also will suggest Master the Board Step 2. That is what I personally used as a student, and kept in my backpack on all of my rotations if I needed to kind of look something up. But I'm very much a visual learner, and that has a lot of images, flowcharts, tables. And so if you're less of a words and more of a visual learner, I definitely suggest the Master the Boards book. And like I said, it was my laptop, my stethoscope, and the Master the Boards book that stayed in my backpack on all of my rotations, and that was about it. Um, so, and then I love Anki. Anki was not a thing when I was a medical student, so I have many a picture of stacks and stacks of handwritten note cards. But now I suggest everyone use Anki because it is such a great resource, and it's really good when you're just kind of like sitting and wanting to review certain things, and helping you, review those things that you've seen a couple of times and you are still getting wrong. So that way it's kind of more exposure.
Great. Yeah, I think one of the things that's important to hear from Kayla's perspective is that the resources she uses and she recommends is going to be different than mine, but the core concepts are the same. Like I personally, I am not a flashcard guy, but I tell all my students if you are, Anki's great. But you should know that there's many different ways to succeed on this exam. I think what we're both highlighting is limit the scope though. Like Kayla's telling you she had like three things in her backpack. That should be the goal, is just a few resources that are very high yield. Awesome. All right. So and this is I didn't realize we have this slide. No comprehensive resource for step two. Do questions and see patients. And we're going to talk a little bit about that. And then practice tests are there to teach and assess. The practice tests, again, they're there to assess, are you going to pass, which should be your first goal? And then are you scoring near your target goal? Okay. So I'm going to open up a poll question. And this is what I'd love for you all to do is just chime in on what you think. What style of studying should you start with? And what we have is subject specific, so just focusing on cardio, just focusing on emergency medicine, mixed, where you blend everything together, or both, where you kind of do a little bit of subject specific and a little bit of mixed questions. I'll give you guys about 15 more seconds just to chime in. All right, we'll give you 5, 4, 3, 2, 1. All right, so here are our results. So Kayla, I'll leave this up to you. What do you think about this spread and this distribution?
Yes. So I think it definitely talks to the fact that everybody kind of has a little bit of a different approach, right? And this is why we are here, to kind of help with managing that approach. I think the importance of this question, right, if we're thinking in terms of strategy for taking our step exam, is what is the question asking, right? So the question is asking, what should you start with? And for me, as we've kind of talked about, I always have my students start with subject specifics because during their slow and steady process during their clerkships. And so that's, kind of how I interpret. And I have most of my students hold off on doing mixed until, they've gotten most of their learning done just for confusion's sake.
Yeah. Yeah, I think that's spot on. And kind of what I actually wrote here was all could be correct, but it depends on when you start. And I think
Mhm.
what Kayla recommends to her students, which is when you're on surgery, you do surgery questions. It's exactly what I recommend. So that's assuming you start early in your clinical year. If you are like day one of dedicated, I've never done a UWorld question, you're probably going to have to do either mixed or both. Subject specific may be a little bit more challenging just because you're likely pretty close to your test date. But I think in an ideal world, what we would recommend is you start subject specific if you are starting early in your clinical year. What I recommend is as you go through each subject, I tell my students finish all of the questions of surgery or pediatrics. So you're clean slate once you're done. If students are doing really well, and like not to throw any shade at psychiatry, but I think that's the one shelf exam that students are like, oh, I actually feel pretty comfortable with this. I'll tell them, hey, if you've got time, try and use some old mixed questions just to refresh what you learned 6 months ago on medicine. And then once your dedicated period comes around, I think it really will go to entirely mixed or a combination of both, where the majority are mixed. And then there's a little bit of subject specific just depending on what your strengths and weaknesses are. Okay. So that's our general approach. Kayla, you have anything else to add on this? Or
Yeah, I would definitely agree. I think, the great thing about getting questions done in the kind of slow and steady process is that, as you've said, when you hit your dedicated study period, you know where your weaknesses are. And so, for instance, if pediatrics is your lowest shelf score and you know that's where you're struggling, you can do dedicated blocks solely on pediatrics and then do mixed blocks. But you don't have to figure that out because you already know where your weaknesses lie.
yeah, fantastic. All right, so we've talked a little bit about kind of how to prepare, what resources to use. We didn't focus too much on practice tests, but know that practice tests are a must. Um, we want to shift gears a little bit now into some of the hard skills that you don't necessarily learn on the wards or in the classroom. And a lot of what Kayla and I focus on in terms of our tutoring is not only teaching you guys medicine and the content, but really how to answer a question. And Kayla was already alluding to that, saying, what's the question actually asking? So what we're going to do now is we're going to go through a question, um, and we're going to ask you guys to some questions as we go through. And the goal here is not to get the question right. It's for you to see how Kayla and I think through this. Okay. So we're going to go through very slow. I'm not giving you the answers. I'm not giving you the image just yet. And then we'll have a poll at the end where we want you to put an answer in. Again, we don't care if you get this right or wrong. The goal is really how do you think through this? So also, I'm biased and I chose a question that's going to be related to the heart, just in case if any of you hate cardiology. So the way, and Kayla, I'll ask you some questions and your thoughts as we go through this, but please chime in. When
Yep.
I start with a question, I always start with the final sentence. So in addition to pain control, which of the following is the most appropriate immediate pharmacotherapy for this patient? So I know the question is, what's the next treatment that we're going to give this person? And it's going to be a drug since it's pharmacotherapy. So you now know that is what you have to focus on. The question is going to be about what drug do you give next? But then think of all the things that come with that. They could ask you, what's the diagnosis, which you're going to have to figure out. Are there contraindications to certain medications? Are there other medications that they're on which would make one answer better than the other? So you already have the ultimate question in your mind, but it should start to bring up what are some things that I'm going to need to consider when answering the question at hand. What is the diagnosis? You always need to know. So I like to start with that. So I then go to the top and I'll say 48-year-old man comes to the emergency department due to severe chest pain that started 2 hours ago. So what I'm going to now ask is everyone in the chat, if you could, I want you to not read anything else. 48-year-old man, ED, severe chest pain 2 hours ago. And I'd love for some people to list out differential diagnoses just based off of that one sentence. Okay. Yeah, so I'll start with one, and I'm going to say myocardial infarction, just to make it so you guys can't pick the most obvious one. So I want to see what are other differential diagnoses that you could have just based off that one sentence. Okay, aortic aneurysm, GERD, costochondritis, perfect. MIPE, aortic aneurysm, GERD, perfect. Good. So this is exactly what I want out of you guys. You're listing, you can come up with 15 differentials. So now we're going to pause and I'm going to change this. And I'm going to say a 48-year-old man comes to the ED due to severe, we'll say severe chest pain that started 2 months ago. What happens to your differential? So now I want someone to give me, or anyone, give me some other differential diagnoses. Some of the ones you had before could be correct still. But let me see, what are some thoughts? So angina, good. Myocarditis. Myocarditis can persist for days to weeks. Dressler syndrome, perfect. If they told us that they just had an MI a few months ago, totally. GERD, Dressler, beautiful. Okay. So I think what you guys are getting at is the first sentence should completely set up the stage. What I always pay attention to is the age of the patient, the sex of the patient, the chief complaint, and if they give it to me, the duration of symptoms. Okay. If this was a 16-year-old woman with severe chest pain for 2 hours, very different differential, right? Still could be an MI, but I would think more vasospasm or SCAD or something else. It wouldn't be plaque rupture. So one thing I'll do when I'm working with my students early on is this skill, which is I'm going to give you an age, sex, symptom, and duration, and you will list as many differentials as you can. Then, as we go through the question, we get more information and we just refine that differential. With the goal being with every question, you should be able to nail the differential or the diagnosis, even if that's not needed to get the question right. And you'll see sometimes you don't need to know the diagnosis to get the question right, but I think it always helps. So, Kayla, what do you think? Do you do something similar? What are your thoughts?
100%. I always tell my students that three things that they need to highlight to focus on are age, presentation, and timing. Because often, even if you are having a difficult time with the differential, those things are going to help you rule out answers in the end as well. But coming up with a differential in the beginning is super helpful. I like to call it my newspaper headline, is what I tell my students. So if you read the first two sentences, what would be the newspaper headline for this patient? In 5 or 6 words. And that really can help you boil down, okay, this is what I'm looking at, and these are the things I need to start to think about.
Yeah, perfect. What one of the things that we want to convey is that a lot of the skills we're teaching you for how to answer question are actually how Kayla and I think clinically when we see real patients. It's the same exact thing, which is why I love tutoring step 2, because it's not only teaching you to be a good test taker, but be a good doctor. Okay, so I'm gonna lead with my differential of MI, but know that we can change it as things come up. So he has difficulty localizing the pain, saying that it hurts all over my chest. For me, that probably rules out some things, maybe like less likely costochondritis, because that should be localized to the costochondral junction. But that's pretty nondescript, so we'll keep going. He has had no shortness of breath, lightheadedness, syncope, or palpitations. So that's really important. There are some diagnoses here that I would now rule out. So shortness of breath, I'm going to get rid of pulmonary embolism, because generally that can present with pleuritic chest pain and shortness of breath. He doesn't have obstructive shock, right? If he had obstructive shock, we'd start thinking about lightheadedness. We'd maybe think about syncope. Palpitations maybe would get rid of arrhythmia, which not always, but arrhythmias also don't normally present with chest pain, but sometimes they can. So now I'm ruling out a bunch of things. He has no known medical conditions. All right, that actually does change my differential a bit. Why would that change my differential if I was leading with MI? He has no known medical conditions, and he's a 48-year-old man. Anyone want to chime in, either in the chat or unmuting themselves? This is a little bit of a more challenging history question. So no history of any condition that will trigger another. Okay, so he has no predisposing risk factors
Good. Yep.
Doesn't have hypertension or hyperlipidemia. Perfect. And I'm assuming, Ghazal, that you're saying that because if we're thinking MI, we would want them to have the things that come along with MI: diabetes, hypertension, hyperlipidemia. Exactly. So I'm now actually reading that one piece of information. I'm going to change my differential, and I'm going to say that he has, um, let's say, it's hard for me to know the differential because I know the answer. Let's say that he has uh, pericarditis, like slow developing pericarditis
That's
over a
exactly
week.
what I was thinking. I was just
Okay,
about to say, I was like, pericarditis would be at
yeah.
the top for me.
All right. So pericarditis, you know, 2 hours is pretty quick for pericarditis, but it could be. It could be. So we'll leave with pericarditis just because young guy, no risk factors. I think that's reasonable. Okay. So his father died suddenly at age 52 from a presumed heart attack. All right. Kayla, what does that do for your differential about pericarditis?
Hmm. So, especially with my pediatrics brain, I start thinking about things that are congenital, right? And things that have family history risk factors. Pericarditis is not necessarily one of those. I think of pericarditis much more of kind of an external factor rather than a genetic factor. So now I'm thinking, well, maybe not.
Yeah, yeah, exactly. So I really hope, I know we're taking forever to go through this one question, but I want you guys to see how our brains are working as we get little bits and bits of information. Our differential's completely changing, right? So now we go into the objective data. So afebrile, hypertensive, tachycardic and regular, and respirations are 16. So I think the things that I take from there is the hypertension, which could still be related to something congenital or genetic, and they're tachycardic. The tachycardia, I'm not sure what that is. If he's having chest pain, it could be a response to the pain, or it could be compensatory for some pathology. They're telling me that it's regular, so my differential was lower for an arrhythmia, but and that may help solidify that. Not all arrhythmias are irregular though, but nonetheless. So on physical exam, lungs are clear and the heart sounds are normal. That rules out a lot of stuff. We weren't thinking lung pathology initially because he's had no shortness of breath, um, and his lungs are clear. So we've ruled out pneumothorax, we've ruled out pneumonia. And in real life, yeah, you can't technically rule those out with just this, but for purposes of the boards, you can. And it also, with his heart sounds being normal, when we think about heart sounds, most of the time, that's cluing us in on the valves. So we've ruled out a lot of valvular disorders. There are some other heart sounds that can happen that are not related to the valves, one of them being the pericardium. We'd be looking for a pericardial friction rub if we're thinking pericarditis. So that's evidence against pericarditis. So we would need to think of another differential right now that I'm not certain of what that is. I think looking at what you guys have all put through, technically it could be costochondritis. We haven't pushed on his chest to see. Could this be an aortic aneurysm? Sure. Could this be GERD? Possibly. This would be a little intense for GERD, but it's possible. Anxiety? Very well could be anxiety. You could be very hypertensive and have chest pain with anxiety. So I think there's still a lot on the differential. ECG reveals sinus tachycardia and voltage criteria for left ventricular hypertrophy and T-wave inversions in V5 and V6. Okay, so now I'm going to argue that there's some um, data here that rules out a lot of stuff. The LVH is they're telling you that likely for a reason. Now, could this still be anxiety? Yes. But if I'm seeing someone with hypertension and LVH, what does that tell me about the hypertension? Is this something that's just related to the pain that he's experiencing now?
I think he probably has more underlying history that we didn't know about.
Exactly. So there's exactly. So when they say patient has no medical conditions, like Jacob and Kayla were saying, this has probably been chronic. So he probably has something brewing, right? And then we get the CT scan. Okay, so before I show you the CT scan, I will always summarize what is going on. And I like my students to try and say, summarize the question in a way that you could tell your classmate the one sentence, and they should be able to get the question right without even, or pick the right answer without even looking at the question. So what I would say is, I have a 48-year-old guy, acute chest pain, who's hypertensive, who likely has chronic hypertension, and has a pretty unremarkable physical exam. Okay, that's how I would summarize this. And he has a family history of early cardiac death. That's, I think, one of the most important things here. So you should be cluing in on a differential right now. Some of you may not know, but the reason I picked this question is because there's an image associated with it. And this is the image that you're going to get. On step 1, you can actually get through most questions if they show you an image without actually knowing what the image shows, unless it's histology. They show you an X-ray, they show you an EKG, you sometimes can get away without not actually knowing what to see. And it's not the case with step 2. With step 2, you really need to start learning imaging, which is why I'm showing you all this. So can people say what they're seeing here? Or if they're what there's, and if you don't know what's going on here, it's okay. Just describe what you see. And they told us that this is a CT of the chest, which if you didn't know that, that's what we're looking at. And is there anything that people see that looks normal, looks abnormal? Okay, so we're seeing Spencer saying aortic dissection, Jacob saying aortic aneurysm, we're getting some more dissections. Exactly. So what we have here is, you guys can see my mouse, is that right?
Mm-hmm.
Okay. So this is your ascending aorta, and this is your descending aorta. And we see this little thing here and this little thing here, and that's a dissection flap. So very good. So that was one of the things. We actually didn't say aortic dissection in our initial differential. We said aortic aneurysm. But this is very much a complication of that. So now what I would do is, we're now coming back to the question, in addition to pain control, which defines the most appropriate immediate pharmacotherapy for this patient. What I would tell my friend, who's to make, and this is a test for me to make sure I know what's going on with the patient, is in a person with an aortic dissection, what's the next best step in pharmacotherapy? That's actually what they're asking you here. You don't need to know anything else after that. Okay. So before we dive into the answers, Kayla, is there anything else that you would have wanted to bring up in terms of test taking strategies, skills of how to get through this?
Yeah. So I love boiling things down to a one-liner, right? When there is a huge stem and there's a ton of information, just boil it down to a one-liner that is in simple words. You don't have to use medical terms. It is simply what is going to make it easiest for you to summarize this giant mass of information. And that's true both on the questions, but also in your clinical rotations. There's nothing more than I love as an attending when a resident can kind of boil things down into a one-liner after I have maybe lost a little bit of attention with my ADHD. Uh, so truly boiling it down is what is really going to help you the most so that you're not getting lost. And by highlighting, like limiting your highlighting to really the pertinent positives, and those like pathognomonic clues is what's truly going to help you create this one-liner that becomes your anchor. So I call this liner creating your anchor for answering the exam question.
Yeah, that's really great. There's a lot of strategy which goes into step 2, and that's what one of the things we want you all to focus on, not only learning the content, but then knowing how to read through the history, the exam, the objective data, and use that to your advantage to not only ideally get the question right, but what happens more often than not is just say what's wrong. You can pick the answers that are wrong. So what we'll do is I'm going to show you the answer choices, and I'm going to launch a poll. I want you all to take your best guess. Again, this is actually probably the least important thing in terms of like what we want you to get out of this question. Know that there is a lot of strategy to going through answer choices, and we're going to talk a little bit about that. We're not going to spend too much time just because that's like, it could be a whole nother lecture, to be completely honest.
I spend some of my tutoring sessions just doing that, weeding
Yeah,
out answers.
yeah. It definitely could be. So, but we want you to just take a guess, and I'm going to show you how I'd go through some of these answers, but not all of them. So please, I would love it if you could just give a guess, even if you have no idea what's going on or what the answer is, just put in an answer in the chat, or sorry, in the poll. And I see some of you are putting that in now, which is fantastic. So I'll give you guys about 30 more seconds, and then we'll do a little bit of teaching on this question and then also really how I'd think through the answer choices. All right. So I'll give you all about 10 more seconds. Please just throw in some answers. Again, even if you have no idea what it is. All right, so we have a C, we have an A. That's in the chat, and then I'm going to show the poll in about 5 seconds. All right, and I'm going to end this. So looking at the results, if we all scroll down, it looks like a lot of people were leaning towards C. We had some people for ACE inhibitor or nitroprusside, and then no one for B, E, and F. So the correct answer is labetalol, which is great, very good. And I want you to think about what I think is really important is when you put your answer in is to look at the spread of answers and to see where were other people thinking. So we had someone pick nitroprusside, and we can see 12% of people also pick nitroprusside. So the first thing I'll tell students to do is what is not the right answer. And I would say the two things I would have ruled out, which no one picked, is E and F. TPA, which is our clot buster, and unfractionated heparin, our blood thinner, don't really play a role, at least at this moment, in the management of a dissection. So I would say what I'm focused on in this patient is lowering their blood pressure and lowering their heart rate. Those are the most important things right now. So I'm going to get rid of E and F. And then A, B, C, and D all achieve some of the things I just mentioned. So I'm ruling things out because I know what I need to focus on first. Now going through ACE, hydralazine, labetalol, and nipride or nitroprusside, that's where you start getting into the more nuanced, okay, what are the strengths of ACE inhibitors over hydralazine? Are there contraindications? So for example, with the ACE inhibitor, I wouldn't want to give that to someone who's having an AKI. I could make that worse. Hydralazine has an issue with reflex tachycardia. That will make this patient worse. Nipride can have a similar reflex effect too. Labetalol will bring the blood pressure down and will block the beta adrenergic receptor to slow down the heart rate. So it gives you two bangs for your buck. So that's why the answer ends up being C. But there's a lot of more skill and test taking approaches that you can take to the answers, which we're not going to cover tonight. But know that in addition to the content, being a really tactful test taker, knowing how to go through the questions, and then importantly the answers, is a skill in itself that you should learn throughout your study. I'm going to stop talking here because I've been talking so much. I'm going to pass things over to Kayla, and she's going to go through the second half of this and then and give you some kind of summary points to take home. Okay.
Thank you. Absolutely. So, as I alluded to earlier, I'm a big fan of understanding what the actual question is that they're asking you, right? So, in this case, they're asking for, in our practice question, the immediate pharmacotherapy, correct? So, we want something that is immediately acting and is going to help us right in this moment. So ACE inhibitors, yes, can lower blood pressure, but we think of those more as kind of long-term medications to keep blood pressures under control, right? So weeding out that answer because of timing, right? That's not what your question is actually asking you. So it's important to understand the question. Is this a first step question? So a first order question is just the diagnosis. Am I just picking what the diagnosis is? Or is this a second or third order question where I need to know the next best step, the initial management, or a confirmation test, or the best test to perform next, right? You have to know exactly what they're asking you. And for me, if you're someone who maybe has a little bit of ADD, ADHD, or gets distracted easily, it's okay to highlight the important part of that question. So immediate pharmacotherapy is what I would have highlighted in here to say like, okay, remind myself that I'm thinking about a drug that needs to act now. In terms of your highlighting after that, so pertinent positives and pertinent negatives are there for a reason, right? The details are there for a very specific reason. What I always tell my students to focus on, which we talked about here, is number one is age, right? Age is going to put you in a huge category, particularly if you're thinking, is this pediatrics versus adult? And then if you're in pediatrics, the differential changes so much based on the age range. So knowing what that age is really helps you hone in. Timing is the next thing. Is this acute? Is this chronic? Is this subacute? Is this reoccurring? That can also help you narrow down that differential. And then from there, this is going to be additional things such as your vitals. Are they abnormal? And if they are, highlighting those abnormal vital signs. If they're normal, you do not need to highlight them. They're not important, right? Every question will have vital signs in them. If they're abnormal, they're there for a reason. And then what risk factors or pertinent exam findings are they giving you, right? Because those risk factors and pertinent exam findings or history findings are what are going to help you create that pathognomonic clue, right? These questions will have a specific detail, and many times where you're like, oh, I've only ever seen this phrase related to this diagnosis. If you see those pathognomonic clues, go with it. Love it. Stick with it. Okay. It's there to help you. That's not supposed to be a trick, right? And this is how you generate kind of that differential. And you really, as we did here, should start generating that differential in the first one or two sentences based on the age and timing and presenting symptoms. Okay. From there, when we say, rule in, rule out, um, this often becomes a process of elimination in terms of your answer choices. If I am not positive what the answer is right off the bat, I say, okay, how can I rule out answer choices the easiest way possible? So I'll say, okay, can I go through any of these answer choices and be like, these are chronic and I'm working with an acute problem. So none of the timing doesn't fit for these ones. So I'm going to strike them out. Use the strikeout tool. I love the strikeout tool for helping to take things kind of off your plate and make you stop thinking about them so that you're only really thinking about two or three answer choices and you don't have to actually think through the rest of them. If some things don't fit for age, get rid of those. If some things don't fit the body system that you're working with, get rid of those. Don't make it hard on yourself. If a part of that answer choice is wrong, the entire answer choice is wrong. Just strike it out and let yourself actually use brain power for the ones that have distractors in them. I don't know if you teach something different, similar, Dylan.
No, yeah, spot on, spot on.
And then really in the end, right, if you truly are if you get down to answer choices and you're like, I have zero idea what this question is asking me or anything related, and I'm not going to get it, pick something and move on, right? So you've eliminated, three of the five answer choices. You're down between two and you have zero idea. You have a 50-50 chance of getting that answer choice right. Pick it, move on, forget about it. Don't worry about it. Don't let it sit in your memory. That's how, if you keep building on that, that's how you're going to snowball into worrying. And I know I'm definitely somebody that can do that where I'm like, oh, I'm still thinking about that question three ones up that I didn't know about. And now I'm not focusing anymore. It's fine. You are not going to know everything. It's just the way it is. And that is okay.
Yeah, I try and tell my students, think of every question as its own independent test. And once you finish that test, you have to move on and just try and erase it from your brain. Even if you nailed it, like you're like, oh yeah, this question was easy. I knew that one. Erase it. Move on to the next one. All right.
Especially on step two when they're all in there can be in very different subjects and you're switching between from peds to surgery to, geriatric, all these sorts of things. You have to move on in between questions. So this is a poll question for everyone. I would love to hear about what everyone thinks is when they feel as though they're ready to actually take the exam. So you've done all your clerkships, you're in your intensive study period, you're doing your studying, you're taking your exams, doing your thing. When do you know that you're ready? When do you feel like this is right, this is a good time? And I'd love to hear what people have to say about that, whether in the chat or in the poll, however you would like to kind of express that.
People, I'm prepping the poll right now. Sorry, I just need to make this uh, right.
We
But it's
also
pretty
could
much,
just do chat. That's totally fine.
yeah,
I
yeah.
would, yeah, chat, talk, like tell me when practice tests give good scores. Okay. Other thoughts?
Well, this is better than the poll.
Yeah, I love this. Exactly. That's why I was like, you know what, just tell me what you're thinking. Mental health is in a good spot. Yes, preach. Um, we never know when we're ready. Just continue to study until daytime. All right, practice test. Good. When my dedicated study time is over.
That's
Sometimes
fair.
yes, it's fair. It feels like that, right? Especially if like school is like, listen, this is when you have to take it by, right? Sometimes there is a deadline where you don't have an option but to sit on a certain day. Okay. But truly, what we want to see is consistency, right? So one good score on a practice test could be luck. Maybe they asked you more questions on that test that are something that you're strong in, so you got a good score. But consistently, when we're seeing a trend where you're hitting your goal on two or more tests, or you're trending upwards, that's where we're saying, hey, this is repeated evidence that you are ready to take this exam. I truly care less about your highest score and more about the trend, right? If you are trending upwards, if you are consistent, that is when you are ready. Go for it. Take the exam, be ready mentally for it, and don't question yourself.
Yeah, I think that's spot on. I never feel comfortable with a student saying, I got my target score, I'm ready to go, if they only got it once.
Mhm.
And I also tell students that expect your score to not change significantly in the beginning. It takes a lot of time to accrue like a critical mass of information to then see your score really start to improve. So consistency and repeatability, those are the key things we care for. And then in terms of like objectively what your score should be, that's very personal. I have here um, the average and then kind of ranges of students who didn't match and didn't match into their preferred specialty. This is from the most recent match year. And you can see that it's kind of all over the board. So I think tailor your studying towards what you want to achieve professionally. If you want to go into dermatology, you're going to have to get a great score. Like, for the step is just one part of the formula, but you can see that there's a lot of overlap between matched and not matched. But the matched tend to have a significantly or have a slightly higher score. But know that if like you're in the 250 range, you're probably okay, right? It doesn't have to be 275, but know that, for example, if you're going into child neurology, if you're scoring a 220, that may limit some of your options. So you may want to start thinking, do I need more time to study or should I pivot? But this is just here to help you think about your career. But the way we suggest kind of assess readiness is exactly what Kayla said. It's consistency and repeatability.
In terms of practice exams, this is something that you really need to make sure that you're focusing on during your study period, right? So when we say they're critical to success, they're critical to success not only to give you information in terms of how are you trending, how are you scoring, is what you're doing working, but it also is helps you use getting diagnostic information in reviewing your questions. So reviewing your questions, I like to say that incorrects can like teach you your gaps, right? Where your knowledge gaps maybe are, but correct guesses can actually teach you where your hidden weaknesses are. So even if you had a gut feeling of like, oh, I know this is right, but I'm not quite sure why, that's important too. And so you want to be able to look at those. And specifically when you're looking through questions, you want to, especially when you're looking at your incorrect questions, you want to figure out why you got it incorrect. Is it because you missed the pathognomonic clue? Is it because your anchor statement, your one-liner, wasn't actually correct and you have something that you told yourself that wasn't actually in the question, right? Sometimes I like to tell students, it's easy to make up history when they only give you a few sentences. In real life, we can ask all those questions and gather all that information, but on the exam, you only can go off of what they give you and you can't make up additional story. And then the other thing is did I actually know the information, right? Or is this a gap that I need to look at? Practically, NBMEs are the closest style, and so we definitely want you doing those. Particularly, I would say I'm recommending that students make sure they're doing 15 and 16, which are the two newest NBMEs for step two, because they include new style questions. And it has the closest style to what your exam is actually going to look like. And there's a blog post and video about those exams to explain how they're different than prior on our website for you to look at if you want more information. But I definitely do recommend those. And then of course, like you get the UWorld ones with your subscription. So use them, right? They come with it, use them. You don't want to let things go to waste. And they're often slightly harder just because they have a little bit more detail in them. They're a little bit more picky, but they're still helpful, right? Especially if you're working on strategy.
Yeah, fantastic. And we did get a question, which I think you kind of already answered, which is best way to review an exam well. I think, like Kayla said, be hyper vigilant towards why you got a question right or wrong. Did I get this right for the right reasons, or did I just get lucky? Did I get this wrong? Okay, how wrong was I? Did I have no idea what the diagnosis was? Or did I know the diagnosis? I ruled out three of the incorrect answers and I was between two of the top two answers. Those are very important things to know because it's going to help guide you in saying, how much time do I need to spend in reviewing this? If you got a question right because you knew the right answer and you were then able to tell me why the other four answers were wrong, don't waste your time. Move on. You've mastered that. All right, we're almost out of time, but we've just got a few final things that Kayla will kind of take us through.
Yeah. So these are really these are just some final resources that EMP can offer for you. Okay. So we talk a lot about, how to study, strategies to study, but also when to study, right? And so we do offer helping to create a calendar one-on-one, but also some kind of just generic calendars through Elite Medical Prep as well. So you really want to make sure that you are taking time to do your cube link, doing timed blocks, but also allowing yourself for review, making sure that you're actually spending time going through those incorrects and finding out why they're incorrect. And then if you're a flashcards or a video person or a reading person, spending time for those as well. Okay. In terms of like an overall calendar, the most important thing is that you pick a test date and work backwards, right? And so you have to kind of know when your end date is and then plug it into your calendar so you can see, well, how much time do I actually have? And then you can say, well, how much what my week topics do I need to spend focus study blocks on those? And how many times do I need to see them? So this is available for, yes, step one are the examples here, but also for step two. And you really want to work on prioritizing your mental health well-being, but also the things that you are weak in, and then the strategy, just building up to the exam with strategy. As part of this talk, I think we talked a little bit about this. Yeah.
Yeah, we kind of went
Yeah.
through this. Okay. Let me
Yeah.
get through here. Okay.
Yes. So, yeah, my terrible picture there. So as part of this webinar, you guys are all going to get a copy of the Master Clinical Reasoning for Step 2 CK. And this is truly to help you develop an approach to answering questions and going through the STEM like we did here today in a clinical manner. Okay. And this will help you both on the exam, but also these are written so that way you can use these in real life too, so that you're actually thinking clinically in both the test setting and in your clinical setting. It really is to help you prioritize what's important and what is fundamental in the question and focus on making those differentials so that you can then answer a second and third order question. Because if you don't know the diagnosis and you're not making those differentials, it makes it more difficult to answer those second or and third order questions about making management, clinical decision making skills, things along those lines. So this really is helpful to try to get you to focus on how to actually look through a question and pull out what's important.
Awesome. Yeah, this is a great resource, and it'll definitely explain a little bit more than what we did tonight in terms of how to go through that question. So really quick, just to summarize, there's a lot that goes into step two. Start early, be prepared, definitely create a plan and a roadmap for your success. Not only learn the material, but learn how to use the material, and then test yourself. We want to see repetition, we want to see success over time, and we want to see consistency. Everything in terms of resources is available on our website where the link is there. There was a question about will this be recorded? The answer is yes. It'll be posted at this link at elitemedicalprep.com/webinar. We have a lot of other resources, blogs, all of the calendars. Kayla's resource as well will be available, and we'll send this out to you as well. And then if you want to chat with us, we're available. We have many other tutors who are available in the company. We spend a lot of time trying to pair you with someone who is really ideal for you, whether that's based off of where you're from, your clinical interests, your scientific interests, or your career goals. But we want to be here to support you all. So I know we're just 2 minutes over, so if you have to run, please feel free. But Kayla and I are here to answer any questions that you have. You can either put it in the Q&A like some of you have been, or just throw it in the chat. And we'll go from there. And we'll stay on just for a few more minutes answering any questions you have, okay? And if there are none, then don't feel pressured. Like if there are none, we'll definitely end it here. But we want to make sure we are available for you guys. And thank you all for coming. And feel free to log off if you have no questions and are all set. All right, well, we may be okay then. Everyone just seems to be thanking us, which I'll always take. So,
I will always take thanks. I absolutely
yes.
love it because
All right.
especially since my 2 and 3 year old patients don't like to thank me very much. Um,
Yes, I will say that also happens in the older population.
okay, good to know. Good to know. They're just as
Uh,
cranky. I love it. I
okay.
love it.
All right, well, we do have a question really quick. I'm studying for Step 2 CK since November, and I'm doing questions and reading. Um, I presume this means am I okay or am I late? Just because I know you said early, but just asking. Kayla, I'll let you answer that. I think it also would be helpful, whoever put this, to let us know when you're thinking of taking the exam. But Kayla, if you've been studying, if someone's been studying since November, and let's imagine it'll be in, let's say, this summer, what do you think?
I think this is great. I definitely think that that is starting early, right?
And they say less than
Um,
3 months.
oh,
So
okay. Yeah.
yeah,
So when we think about, right, when we are talking about starting early, we're talking about starting at your clinicals, right? And so that really is like the whole of your NS3 year. So if you started in November and you're taking another 3 months from now, right? That's about the whole time that somebody would be spending in their clinicals in MS3 year. So great, you should have plenty of time to have gotten through all of your U world questions and then also have a mixed period at the end.
yeah, yeah, I agree. I think you're doing great. So yes, I did my boards and everything, finished elective in school in November. Okay, great. Yeah, I think you're on. It sounds like a good timeline. Again, remember the timeline is going to be different for everyone, but to be safe and to be conservative, we say start early, and I think you're definitely on the right path. All right. Any other questions? Last chance. All right.
You're most welcome.
Okay. Cool. Well, thanks everyone for coming. Again, this will be posted online. If you want to see this, there's also a ton of other webinars if you're interested, but feel free to reach out to us. You can set up a free consultation, and best of luck with your boards and all in medical school. All right.
You
Thanks,
got this,
everyone.
guys. Confidence is key.
Of course. All right. Everyone, have a good night, okay?